Hello guys, welcome to my YouTube channel Study for MBBS Exams. So today we are going to study about SLE and rheumatoid arthritis. So what is this SLE? So SLE is a chronic autoimmune disease. So it's an autoimmune disease which affects multiple organ systems. And what is this rheumatoid arthritis? Even it's a chronic autoimmune disease which primarily involves joint but also it affects other system. Okay, so what is female is to male ratio in SLE? It's 9:1. What does it mean? If 9 females are affected, only 1 male is affected. And what is the female is to male ratio in rheumatoid arthritis? It's 3:1. That means if 3 females are affected, only 1 male is affected. So, which is the most common age group in SLE is affected? It is reproductive age group females. And which is the most common age group where rheumatoid arthritis is seen is 40 to 60 years. Okay, so now we are going to study pathogenesis of SLE. So there are some genetic factors plus a estrogen exposure. This could be in form of OCPs or hormone replacement therapy, leading to defective apoptosis, which leads to activation of innate immunity and adaptive immunity. Okay. So now antibodies are produced against these apoptotic bodies which lead to immune complex deposition. Okay, we got the pathogenesis of SLE. Now we are going to study the pathogenesis of rheumatoid arthritis. Even it's almost same. So first there is a genetic factor, then the person smokes. This leads to abnormal protein modification. The problem is in citrullination and carbamylation. Again, this leads to activation of my innate and adaptive immunity. This leads to release of TNF alpha, which activates osteoclast and inhibits osteoblast, which leads to osteoporosis. So what all we understood in this page? Definition, female is to male ratio, age and pathogenesis. Okay, so now we are going to study about clinical features. So clinical features of SLE and rheumatoid arthritis. So we'll study in a different way. So the clinical features seen in CNS and PNS. In SLE, it is stroke, cognitive disorder, psychosis and depression. And in rheumatoid arthritis, we see PNS neuropathy. The manifestation in eyes. In SLE, we get dry eyes because SLE is associated with Sjogren's syndrome. And in rheumatoid arthritis, we get episcleritis. Now, heart. In SLE, we get pericarditis and Liebman-Sachs endocarditis. In rheumatoid arthritis, pericarditis is common, but we get mitral regurgitation in rheumatoid arthritis. Now, manifestation in lungs. Pleuritis and effusion is common in both SLE and rheumatoid arthritis, but in SLE, vanishing lung syndrome is seen. And in rheumatoid arthritis, we get Kaplan syndrome and interstitial lung disease. Now, manifestation in vessels. In SLE, we get vasculitis and atherosclerosis, and it holds good for rheumatoid arthritis. Here also we get vasculitis and atherosclerosis. Now, we are going to see hematological manifestation. In hematological manifestation, both manifest as pancytopenia. Then, the manifestation in kidney. We get lupus nephritis in SLE and membranous nephropathy in rheumatoid arthritis. Manifestation in GIT. We get diarrhea and autoimmune hepatitis in SLE, and rheumatoid arthritis increases the risk of HBV infection, that is hepatitis B virus infection. Now skeletal manifestation. Skeletal manifestation in SLE is upper limb is involved. In rheumatoid arthritis, upper limb is involved. Then in SLE, symmetrical joints, and in rheumatoid arthritis, it's symmetrical. Then in SLE, small joints are involved, and in rheumatoid arthritis, again small joints are involved. Till this point, everything is same in SLE and rheumatoid arthritis. So what is the catch point? In SLE, there is no erosion of bones, but in rheumatoid arthritis, there is erosion of bones. Why there is erosion of bones? We just now studied there is activation of osteoclast and osteoblast. Okay, we got this point, no? So next, what are the skin manifestation of SLE? We get malar rash, discoid rash and annular rash. And what are the skin manifestation in rheumatoid arthritis? We get rheumatoid nodules. Okay, so how do you remember these clinical features? Just remember, all the sites involved are where one form of liquid is converted to other form of liquid. Example, in CNS, my blood is converted to my blood is converted into CSF. In my eyes, blood is converted to aqueous humor. In my heart, blood is converted to pericardial fluid. In my lungs, blood is converted into pleural fluid. In my vessels, blood is converted into interstitial fluid. And hematological, so you know no blood only. Then in kidney, blood is converted to urine. In GIT, blood is converted into bile. In skeleton, blood is converted into synovium. And in skin, we get sweat. Okay. Now, what are the deformities seen in SLE? In SLE, we get scar in discoid rash, and in rheumatoid arthritis, we get zigzag deformity, swan neck deformity, buttonhole deformity. So, what are the investigations done in SLE? We do ANA profile, and in rheumatoid arthritis, we do anti-CCP and rheumatoid factor. So, how do you diagnose SLE? We diagnose SLE by SLCC classification criteria. If more than 4 criteria are involved, then it is SLE. In that, at least one should be clinical criteria and at least one should be lab criteria. And how do you diagnose rheumatoid arthritis? We do ACR and ULR criteria. If score is more than 6, then it is rheumatoid arthritis. Now, how do you manage SLE? If mild SLE, we manage with oral steroids. If moderate SLE, we manage with methotrexate. If severe SLE, we manage with IV steroids. And if it's resistant to steroid and methotrexate, we give rituximab. Now, how do we manage rheumatoid arthritis? We manage with DMARDs. Which is the drug of choice? It is methotrexate. So, just for revision, we studied about definition, we studied female is to male ratio, we studied about the age group involved, we studied about the pathogenesis, we studied about the clinical features, we studied about the deformity, we studied about the investigations, we studied about the diagnosis, and we studied about the management. Thank you guys.